Sure.
Yes, definitely.
Okay, thank you. So, HiDoc team, once you will give me go ahead.
Yes, I'll let you know.
Yeah, you share that agenda today.
Okay, sir. 1 second, sir. We are live, sir. We can start.
Okay. Can we start?
Yes, sir.
Okay. Good evening, everyone. My name is Ankit Sachdeva. I am working as a regional business manager for All India Inflammation and Immunology and Rare Disease Business for Pfizer India. On behalf of Pfizer, I welcome you all today at the Growth Update. We have Dr. Prashant Patil sir from Mumbai as a moderator and speaker, along with co-speakers, Dr. Sumit Arora ma'am from Gurgaon and Dr. Aniket Kumbojkar sir from Kolhapur. Sir, ma'am, I welcome you all at the Today Growth Update, and I take this opportunity today to introduce Dr. Prashant Patil. Sir is a consultant pediatric endocrinologist and diabetologist at SRCC NH Hospital, Apollo Hospital Navi Mumbai, and Zen Multi-Speciality Hospital Chembur, Mumbai. Sir will be helping us learn more on overview of short stature in India and introduction. Sir, I request you to take this virtual session further from here and help us learn more on the subject. Sir, over to you, please.
All right. So very good evening to one and all. Start sharing my presentation. At the outset, I would like to thank Pfizer for giving this opportunity and a platform for Oath for Growth. This is really a wonderful thing. Today, we will be discussing about a couple of topics really. First, we will see what is the overview and prevalence of short stature. Then we'll go to Sumit. She will guide us about different spectrums or the clinical spectrum of short stature. And then we will discuss something about SGA. We often ignore the growth in terms of SGA. So in last session, we will see the case-based approach. Today's flow of presentation, we try to make it a case-based scenario so that it interests everyone. Since I'm moderating this session, I would request all the guests or the audience to, if they have any queries, they can just put it on the chat box or they can raise their hand at the end of the presentation of each speaker. We'll take Q&A sessions. If we have constraint of time, then maybe we'll take the questions at the end. So with this introduction, I'll start my own presentation. So we will see in next 10 minutes, maybe this is just a brief presentation about overview of short stature in India. This is the disclaimer from Pfizer that this particular presentation is for the HCP only. So to begin with, there are certain myths when we talk about the short stature or rather growth. If you come across, I mean, there will be unison in pediatric endocrinologists that whenever we see a short stature case, most of the parents tell us that, it's absolutely fine. My child is just 15-year-old and they continue to grow till 18 years of age. So this is one of the biggest myth that the child grows till 18 or 20 years of age. It's not true anymore. As we know that age of puberty has reduced, the onset of age of puberty has reduced significantly. So they do not grow till 18 or 21 years of age. In fact, girls generally do not grow once they start their menstrual cycles. So on an average now, Indian girl, they menstruate at around 11 to 12 years. So after 12 years, they generally do not grow. Second, often they've been told, maybe rightly or wrongly, that if they are short, it's fine. Probably during the puberty, they will catch up. So it is partly correct. So it is not entirely correct. Third, that, if you do certain exercise like cycling, pulling, it will increase your it will increase your height to a certain extent. So That is again a biggest myth, and it needs to be busted, that no amount of physical exercise per se will increase your height. Yes, exercise will, increase your stamina, your endurance. It will make you fit. It will make you lose your weight. Probably you will get your target potential or genetic potential, but per se, it will not increase your height. So these are certain myths. When we talk about the definition of short stature, it's an oxological criteria, as we all know. First criteria is whenever the height of the child is below the third percentile, or it is -2, less than -2 standard deviation below the median for height, age, gender, and the ethnicity. And thirdly, if the child is within just about normal centile, but is much too shorter for his parental height or a mid-parental height, then also a child warrants an evaluation for short stature. So this is a oxological definition. We all are aware about the first criteria, that is below third percentile. And the same criteria has been incorporated in our daily to day use growth chart. So this is Indian modified IAP growth charts, which you all are aware. We are using this from 2015. I'm just highlighting the lowermost centile, that is third percentile. So any point of your child's height, which is below this particular line, as I've shown from the red dot, classifies a short stature. So the third percentile is most important, and it roughly corresponds to -2 standard deviation. So third percentile roughly correspond to -3 standard deviation, or accurately -1.87 standard deviation to be precise. So all of you must be aware of these growth charts. Dr. Sumit will tell us about the uses of growth chart and the evaluation of short stature in subsequent lecture. Now, just few of the epidemiological studies and prevalence of short stature in India. There was one of the studies by Firke in 50 children of pathological short stature, and it has been found out that out of these 73% of pathological short stature, almost 77% of pathological short stature was a proportionate short stature, and male to female ratio was 1:1.4. The commonest etiology being the chronic systemic disorder. There was another large study in 16,000, almost 16,000 children from Tamil Nadu, which has identified that the short stature prevalence is somewhere around 2.86. And remember, this prevalence has remained constant all throughout those 20-25 years. The incidence of short stature reported from various hospitals in India till 2010 was 5.6 to 13.8% of range. And the physiological short stature were predominantly the commonest cause. One may be a familial short stature, the other being the constitutional delay in growth and puberty. One of the study revealed that still in India, the protein energy malnutrition and chronic systemic disorders are the important etiology for the short stature. Next comes the physiological short stature, which include the familial short stature and constitutional delay in growth and puberty. Now, having said that, nowadays, with the recent advances, the familial short stature it's now considered to be a variant of pathological short stature. They have identified one protein called aggrecan, which is present in the cartilaginous plate, and the mutation in aggrecan is associated with a familial short stature. So maybe a familial short stature may not be 100% a physiological or a normal variant short stature. Also, there are multiple studies from Kolkata in almost 2,000 children. They have identified hypothyroidism, GHD, and a chromosomal anomaly as a commonest etiology. Now, if we divide, there was an interesting paper which is published recently in 2021 in IJEM. So what they have done, they have highlighted all the studies from 2000 onwards regarding the prevalence of short stature, which has been reported in India. So there were total 6 studies. The 4 studies was done in second decade from 2010 to 2020. And there were 2 significantly major studies in first decade. Now, across all the 6 studies, what they have found out that hypothyroidism uniquely is the most common endocrine cause. It's not a growth hormone deficiency. And in fact, in some cases, it is a second etiology after the physiological short stature also. Now, there are certain discrepancy in the contemporary reports which has been reported from North India. In one of the study centers, it has been reported that a skeletal dysplasia is the commonest etiology of short stature. This is probably because it's being a tertiary institute, rather genetic institute. So the referral to that particular institute is also important, and that may be the reason for which the skeletal dysplasia may be the commonest cause of short stature in that particular study. Now, it was very interesting when they have studied this particular short stature scenario in India. Initially, they have found out that during the first decade, that is from 2000 to 2010, it is the pathological short stature etiology was predominant, and in that the chronic systemic disorders was a rank number 1. Whereas it has transitioned from 2010 to 2020 to normal variant or a physiological short stature, which is quite interesting. And probably this shift tells us that we are much, there's increased awareness. We are treating our child more, accurately and correctly. And we are treating the chronic systemic disorders way too early because of the increased access to the healthcare services and awareness about the growth in patients as well as in school. So that is one good thing, that we are seeing this technotic or a metamorphological shift from a pathological short stature to a physiological short stature. Also, the etiological differences may mirror the socioeconomic and the literacy state of the community, since we are controlling our nutrition, or rather controlling the malnutrition and chronic systemic disorders properly. Interestingly, all throughout that, despite being shift from a pathological short stature to a normal variant short stature, the etiology or the prevalence of short stature rather has remained almost unchanged, from maybe from 2.8 to 3.7%. So it has remained constant between 3 to 4%. And statistically also, if you see in a class of 100, you're bound to see 3% of the children which are below the third percentile. So this is quite interesting. The shift, despite being a shift, the short stature percentage is almost statistically correlating, near about 3 to 3.5%. The transition in the profile and the etiological and the etiology of short stature possibly tells us about the improved economy, the education, and access to basic healthcare. Though the prevalence of short stature has remained reasonably stable, the metamorphosis in the etiological profile deserves its attention. Across India, whether it's a North India or South India, hypothyroidism remain the important endocrinological etiology. And if you talk about the pathological short stature, it's the chronic systemic disorders. And I would say, poorly managed chronic systemic disorders are more common cause of a short stature, something like thalassemia, chronic renal disorders, chronic gastrointestinal or liver problems are important causes of short stature in India till date. So just to summarize, stature being a continuous and actual cumulative phenomenon, and it is usually diagnosed later than sooner. So it is our cumulative responsibility, or that we have to diagnose this particular condition early. The height velocity is often ignored, but it is an important clue for the diagnosis of short stature, which can be easily obtained by regular anthropometric records. So if you check the school records, even per annum, probably we will see the derailment of height velocity. Educating the schools and the primary healthcare providers about the importance of at least annual anthropometry, it will aid in timely diagnosis and early referral for short stature. Children with chronic disease of any etiology, referral to pediatric endocrinologists for further evaluation of growth and ruling out the concurrent treatable hormone deficiency can significantly improve the adult height of the child. And it is it is the need of the hour that we should come with our own national program or national policies to target screening for childhood stunting in identified high-risk area, and that will certainly go in correcting and getting and achieving the child towards his final height. So with this, I conclude my presentation. Thank you so much. With this, I'll introduce you to the second speaker of the session, Dr. Sumit Arora. Dr. Sumit Arora is a consultant pediatric endocrinologist at Artemis Hospital, Gurugram. She has done her pediatric endocrinology fellowship from New York, and she will be taking us through a clinical spectrum in short stature in some case-based manner. So over to you, Dr. Sumit.
Thank you, Dr. Prashant. That was a beautiful overview of the epidemiology of short stature in India. And we are seeing much more of physiological short stature now being identified as a mild spectrum of pathological short stature, like you have beautifully outlined. And I would like to thank you for having me here in this growth update, and as well as Pfizer for organizing this event. So with that, I would like to start, and I'll be going over some case scenarios that we see in our busy OPD. As a general pediatrician, everybody's seeing different clinical spectrum of short stature, and I'll be going over some cases, and in the end, I'll be going over briefly the outline in a very simplified manner how to approach it. I hope my slides are visible easily.
Yes, they are.
Are they moving? Yeah. So
Yeah.
This is the disclaimer. So we are going to be answering some questions. We're going to be answering these in a very question-based manner. We'll look at first the varied physiological mechanisms that go behind a growing child. We'll be looking at the normal variants and the gray zone in the normal physiology, like Dr. Prashant has mentioned, the case scenarios in pathological short stature, and ultimately an approach towards diagnosing them. So let's look at what goes in the normal physiology of a growing child. So when we talk about growth, we're talking in terms of skeletal growth, and it all starts with the growth plate. Now, growth plate is divided into several zones. First is the resting zone, then we have the proliferative zone, and then we have the hypertrophic zone. Now, this is under the control of various mechanisms. When we talk about it, we're usually looking at only in terms of the endocrine aspect, but there's much more to it. So the endocrine regulation has several hormones that are involved in this growth plate. First is the growth hormone IGF-1 axis, which is a very obvious axis where the growth hormone as well as the IGF-1 have a direct regulation towards the growth and changes in the growth plate that happen. Thyroid hormone in itself also has a direct role in this growth plate regulation. Estrogen is responsible for increasing the growth plate senescence also. So it not only increases the growth, but also leads to senescence of growth plate. And that's why it has been seen that once we have reached the growth spurt, the growth plate fuses. Then we have glucocorticoids that are inhibiting this growth plate. Nutrition with the help of leptin and other complex interplay of other hormones has a positive effect on the growth plate. Then we have the extracellular matrix, the paracrine signals that in the growth plate itself have an intrinsic role in the growth plate modification and the proliferation and the hypertrophy of this zone. Then there are inflammatory cytokines that have an inhibitory role in the growth plate. Now we're going to see later on how all these are going to affect the growth plate in terms of pathological process. So let's look at some normal variants that most of us see in the busy OPD. So this is our typical 12.5-year-old girl who's presenting with short stature. She does not have any significant past medical history. Her birth history is significant for a birth weight that was normal, and she had no perinatal complications. Her height is at the 3rd percentile, and as you can see, the target height is between the 3rd and the 10th percentile. And she has a beautiful growth velocity as recorded in this growth chart. And she's in the mid-pubertal area. This is, yes, familial short stature. It's not a no-brainer. So this is the most common variant of short stature. And the projected height is within the family height and the growth velocity is normal. To calculate mid-parental height, just a refresher, we average the mother's height and the father's height and add 6.5 for boys and take away 6.5 for girls. And this is a plus minus 1 standard deviation where we calculate the target height, which is plus minus 6 or 6 to 7 centimeters. Now let's look at the second common variant. This is a 15-year-old boy, again for short stature, family history significant for history of delayed onset of beard at the age of 16 to 17 years. This boy is growing at the 3rd percentile, but his family height is at the 25th percentile. He is prepubertal and his bone age is slightly delayed. And when we follow him over time, his growth starts to normalize. He enters his puberty later, but he reaches his target height. So yes, this is constitutional delay of growth and puberty, and he achieves a normal height as per the family height. So this is the second most common cause of short stature, much more common in boys. There is usually a strong family history of one of the family member, either father or maternal uncle, who has had delayed onset of beard development. The weight and height are tracking along, usually on the lower percentiles. The growth velocity tends to be normal, and the bone age and the height is not much below the mid-parental height. The bone age is slightly on the delayed side, and they catch up once their puberty hits. So let's look at some gray areas in this normal variance. So you have this similar girl who fit in the familial short stature. She's growing around the 3rd percentile. The family is, and she's following along the family height. But here we have a clue where the maternal height is 4'10", which is significantly short, and the target height is also very less. Now, this will not be considered the usual typical familial short stature, just like Dr. Prashant had mentioned. This is the genetic short stature, and the history would be very typical where one of the parent is very, very short, especially in females less than 4'10", in males less than 5'2", and there's a high likelihood of some autosomal dominant inherited genetic mutation, either skeletal dysplasias or growth hormone deficiency. And we do want to rule out other common diagnoses like celiac disease and hypothyroidism. Now, this another scenario similar to that CDGP, constitutional delay of growth and puberty. Now, this again, the boy has is growing along the 3rd percentile. The growth velocity is normal. The family history is significant for maternal uncle having delayed onset of beard, but on review of systems, he described a decreased sense of smell that was noted at 10 years of age. His target height is at the 25th percentile, and he is prepubertal, and the bone age is delayed. When he was followed up closely, he continued to have delayed pubertal exam, and it was later found out that there was a maternal uncle that reported that delayed onset of beard development also had a history of infertility, and genetic testing done showed Kalman gene mutation, and the diagnosis of Kalman syndrome was confirmed. So we have to make sure to ask the family history very closely, because CDGP is a diagnosis of exclusion, and we want to make sure to not miss a diagnosis like idiopathic hypogonadotropic hypogonadism, acquired growth hormone deficiency, or even SGA that have failed to catch up. So some concerning history that you may get is there has been subnormal growth velocity, or there were some red flags like there was micropenis or history of cryptorchidism, or there's reduced sense of smell. If there is significantly delayed bone age, or the height is much lower than the target height. All these are the red flags where you might need to think about some other diagnosis. Let's look at some case scenarios of pathological short stature. So this is a full-term male baby that was born to healthy parents but had history of consanguinity. The birth length was very low. The baby had micropenis and stretched penile length was significantly low with undescended testicles, and had short webbed neck and limited neck rotation. This baby was lost to follow-up initially, but at 3 months of age, came with hypoglycemic seizure, and at that time, further investigations were done, and the baseline investigation showed all the hormones that were deficient. An MRI that was done showed small pituitary gland And a genetic study confirmed a homozygous missense mutation of LHX3 gene, which is one of the transcription factors responsible for development of the pituitary gland. Appropriate treatment was started, and initially hydrocortisone was started, followed by levothyroxine and then growth hormone therapy, and the child started to have catch-up growth. So when do we suspect a diagnosis of congenital hypopituitarism? Usually they have a birth weight and length that is normal, because growth hormone in itself doesn't have a very big role in the growth of the fetus. If there is IGF-1 deficiency, then yes, the length may be affected. Usually they have very non-specific symptoms like lethargy, apnea, poor weight gain, and feeding problems. Anytime if there are any kind of CNS manifestations like holoprosencephaly, if there is rigid neck, or if the eye is involved, then the index of suspicion goes really high. Most of the time, they also have some degree of prolonged jaundice, and this may be cholestatic also. And if this child is having seizures that are hypoglycemic, suspect that there may be both underlying ACTH and growth hormone deficiency. Most of the times, these babies grow okay until later on when they start to have growth failure after infancy. So this is our second patient, who is an 8-year-old who presented with chronic fatigue and tiredness. His past history was significant for some degree of anemia, and his height was less than 3rd percentile and a target height of 25th percentile. When investigations were done, he was found to have celiac disease. His PTG IgA was significantly elevated, and which was biopsy proven, and gluten-free diet was started, and he had a good catch-up growth. Short stature can be present in 33% of the times at diagnosis in celiac disease. And a lot of times we as ped endos also get referrals for short stature, and we find out that they have celiac disease. And usually the height may be affected if they have younger age of onset, if the antibody titers are very high, if they have severe symptoms, and it may be the only presenting symptom in older age, which we're not very clear why does that happen. And gluten-free diet, once it's started, there is significant catch-up growth with the maximal growth that happens in the first 6 months. And we have to make sure if it is a female that we evaluate the child for Turner syndrome. If the child is failing to catch up after gluten-free diet has been started, rarely growth hormone deficiency may be present, and that needs to be evaluated. Okay, this is another patient who is a 4-year-old female with history of delayed walking and short stature. The height is significantly low, less than 3rd percentile. There is a significant family history of mother and sister with short stature and similar bowing of legs. And the exam was significant for widened epiphysis, rachitic rosary, and genu valgum. Anybody wants to give their thoughts on diagnosis? Maybe put it in the chat box or something. Okay, so then we'll move on in terms of the investigations. So the initial calcium was 9, the phosphorus was 3.5, the vitamin D was significantly low, and 125 vitamin D was 26, and the intact PTH was slightly on the higher side. So our provisional diagnosis is, when we look at this phosphorus, we can probably tell that this is X-linked hypophosphatemic rickets. Now, I would want you to focus on the reference ranges here of 3.5 to 6. We may not be alerted by the lab that this range is on the lower side and the child has a phosphorus that is low, because they may be giving you the adult age references for phosphorus, and you may not be getting an age-based reference for the age-appropriate child that the phosphorus should be. So our index of suspicion should go when we are looking at a vitamin D that has normalized, alkaline phosphatase that is still elevated, and phosphorus that is persistently low. We do have to suspect X-linked hypophosphatemic rickets. They usually have features of rickets that are similar to any other rickets. The PTH is near normal usually. And once vitamin D is normalized, you will still not see a change in alkaline phosphatase levels. And there is significantly strong family history of short stature, and dentition is usually involved in these patients. We treat them with oral phosphorus and oral calcitriol. And there are newer treatments like burosumab that bind to FGF23, that is the basic pathophysiological abnormality seen in X-linked hypophosphatemic rickets, but it's still not yet available in India. And these are subcutaneous injections that are given. The other type of vitamin D dependent rickets are nutritional vitamin D deficiency. We have those hydroxylation deficient rickets where either 25-hydroxylase or 1-alpha hydroxylase could be affected, or vitamin D receptor resistant defects where all of them can cause short stature. So let's look at this patient 4, who is a 13-year-old female with history of bicuspid aortic valve with concern for delayed puberty. Height is significantly on the lower side. Target height is at the 25th percentile. Examination is she has slightly increased carrying angle, low posterior hairline, and her SMR is breast stage 1. Now, this is a no-brainer. This is a very short diagnosis that this child has Turner syndrome, but we've already missed the window of opportunity. 30 to 40% of the time, Turner syndrome is diagnosed due to delayed puberty, whereas they should be diagnosed much earlier because growth hormone can be started as early as 4 years of age. And there are subtle clinical signs that may be missed, and they may not always have the typical physical stigmata that we talk about in Turner syndrome. And whenever you're having a girl child with short stature, it is best to go ahead and order karyotype as a first-line investigation. And it's important that we order a 30 or a 50 cell metaphase count. So this is the last patient, a 7-year-old girl with vaginal bleeding. Her height is much less than the 3rd percentile, and she started to fall 2 percentiles in the last 3 years. Her ultrasound showed multiple ovarian cysts, and she started repeating grades in school. So this child has had a TSH of very, very high, of more than 500, and T4 was significantly low. But why did she present in vaginal bleeding is the question, right? So this is what is called von Wijk-Grumbach syndrome, where the TSH, the alpha subunit of the TSH, cross reacts with the FSH and the LH, and it's the one responsible for ovarian cysts and thus estradiol production, and then we start to have bleeding. And once treatment is started, there should be very slow thyroxine hormone replacement when we are replacing it, because these children can go and start their central precocious puberty, and then the height advantage will be lost. So it is better managed by a pediatric endocrinologist. Let's look at a very simplified approach towards diagnosing short stature. So first, let's look at the same growth plate now. And we can see that growth hormone deficiency is one cause that we can easily identify when we're talking about growth hormone axis that is affected. We have hypothyroidism. Chronic use of steroids can affect the growth plate. Precocious puberty with excess estrogen when it is released can initially cause growth spurt, and eventually the height starts to get affected. Malnutrition or malabsorption of any sort can again affect the growth plate. We talked about skeletal dysplasias, achondroplasia, hypochondroplasia, or spondyloepiphyseal dysplasia, rickets. All these things can affect the extracellular matrix and eventually affect the growth plate. Turner syndrome or any sort of chronic inflammatory disease that is uncontrolled will lead to higher inflammatory cytokines and thus affect the growth plate. So when we're talking about the approach, firstly, the first question to ask is, what is the birth size? If the weight or the length are not appropriate for the gestational age of the child, and the child has not caught up to their family height, we have SGA as our consideration, and these children can be started on growth hormone right away once they have reached a certain age of 2 to 4 years. If there is strong family history of delayed puberty, we do have to think about CDGP, but we do have to remember the clinical history. If there is any concerning history, whether we need to evaluate for other causes. If the growth velocity is affected, again, we think about endocrine illnesses. If we have abnormal body proportions, we do go ahead and do the skeletal survey. If clearly the weight is much affected than the height, we think about systemic illnesses, and our investigations are catered to that. And if the height velocity is affected, or if the height is much more affected than the weight, then we think about endocrine evaluation. When we are measuring when we are talking about disproportionate short stature, it is best to get a sitting height and measure the lower segment. The upper segment we calculate by taking the lower segment away from the height. If this upper segment to lower segment ratio is increased, we're thinking about something that is affecting the limbs, like rickets or achondroplasia. If it is decreased, so the trunk or the spine is affected, so we're talking about vertebral anomalies or spondyloepiphyseal dysplasia. So our first line of investigations when we're talking about in our busy OPD are to rule out chronic systemic illnesses. We would want to evaluate for renal tubular acidosis, or if rickets is one consideration that we have. Hypothyroidism is a very common scenario that we see in India, so that would be one thing that I would go for. Stool analysis to look at malabsorption or for worms. Celiac disease, again, malabsorption, or we may have to do a Mantoux test or chest X-ray to rule out TB also. Then our second line investigations, we look at IGF-1 level and growth hormone stimulation test we're going to talk about in a minute. We may have to consider skeletal survey if there is disproportionate short stature, and bone age if the height is much affected than the weight. Karyotype may be a part of initial investigations in any girl that has short stature. Now, growth hormone provocative testing is a very tricky test. There is no sole criteria to diagnose growth hormone deficiency, and there are a lot of gray zones in it. The cutoff is not clearly established. Previously, it was more of a 10 nanogram per ml peak that we would clearly say that this is not growth hormone deficiency, but now we're talking about 7 nanogram per ml. Any child that has obesity, the peak is blunted, so we may have a falsely positive test. Malnutrition, we have higher peaks, and in 10 to 24% of the situations, we may fail growth hormone stimulation test. And priming with sex steroids in a peripubertal child may be needed, and there is no set standard to how to prime these children. MRI of the pituitary gland and hypothalamus is something we may have to consider if we are suspecting tumors or if there is growth hormone deficiency that has been established. Genetic testing may be required in those that are suspected to have skeletal dysplasia, or if hypophosphatemic rickets is something that we are suspecting. Talking about management principles, it is, of course, we have to treat the underlying cause. And the earlier the treatment is started, the better in terms of the catch-up growth. And in most conditions, including rickets, hypothyroidism, chronic illnesses that are well managed, the catch-up growth is very rapid, and usually they do well in terms of the height prediction. Early growth hormone therapy in FDA-approved condition usually preserves adult height. And it is very important for those that are syndromic or have genetic short stature that does not have a treatment, they also undergo psychological counseling. Some FDA-approved conditions that are for growth hormone therapy are growth hormone deficiency, small for gestational age with no or poor catch-up, and this includes Russell-Silver syndrome. And then we have Turner syndrome, chronic kidney disease, Prader-Willi syndrome, and idiopathic short stature. When we are starting growth hormone therapy, we do have to make sure that we have established growth hormone deficiency. And the treatment of other hormone deficiency in case of multiple pituitary hormone involvement has to be initiated before growth hormone therapy is started. And it is always important to have a consent to treat the cost has to be told upfront because it's a very expensive treatment, and side effects should be discussed upfront too. And when we are starting growth hormone therapy in idiopathic short stature, it's important to discuss the benefit risk ratio, and that we may not see a very good height prediction, or we may not see any response at all in idiopathic short stature. And it's very important that growth hormone therapy is discontinued timely if there is no growth velocity goes below 2 centimeters per year, or if the bone age already shows growth plate fusion. And it is also important that we do document adult growth hormone deficiency, and if needed, growth hormone therapy should be continued during adulthood also. So our predicted adult height with growth hormone therapy is dependent on when it is initiated, what age, what is the pubertal status of the child, how is the family height, and the dose that we are initiating it. Usually for growth hormone deficiency, if it is started timely, the gain of height is as per the family height. In SGA babies, which Dr. Aniket is going to talk about in much detail, there's an additional gain of usually 10 centimeters. Turner syndrome also, there is good growth of 8.5 centimeters, and if it is started much earlier, there is a higher height gain. And Noonan syndrome, 9 to 10 centimeters is what has been reported. So the key points when we are talking about growth plate, there's much more understanding that is needed, and it is not just the endocrine anomalies that we're talking about in terms of growth being affected. Endocrine regulation in itself is very complex, and there are varied presentations that we have seen just now in these case scenarios. And we can significantly improve predicted adult height if we start growth hormone therapy much earlier, especially in growth hormone deficiency, SGA, and Turner syndrome patients. With that, I would like to end my talk, and we'll be happy to take questions later.
Thank you, Dr. Sumit. It was wonderful presentation, very crystal clear cases, very nice mixed bag of interesting cases. And you have highlighted nicely that the growth failure treatment has to be initiated early with your cases like Turner syndrome and other pathological short stature. So thank you so much. There are a couple of questions. We'll take the Q&A sessions at the end of it.
Thank you, Prashant.
Invite our next speaker, Dr. Aniket Kumbhojkar, who will taking us through a case scenarios in SGAs and the growth failure in SGA. Dr. Aniket is a consultant pediatric endocrinologist at GrowKids Endocrine Clinic at Sangli and Kolhapur. He has done his pediatric endocrine fellowship from Pune and later the SP fellowship from UK Birmingham. And he will take us through the important topic of SGA, as we have covered previously, that it is often ignored. The problem with SGA referral is the late referral across the globe. And in India, we generally do not see them before they are into their puberty. So Dr. Aniket will take us through the case-based scenario. Over to you, Dr. Aniket.
Thank you, Prashant, for that kind introduction. It is a wonderful platform to discuss such important topic. And I would like to share my screen now. Okay, so can you see the presentation?
Yes, we can.
So basically, we are born naked, wet, hungry, and then things get worse. So what is SGA? Basically, we will discuss the definition, which is not straightforward actually. It requires following accurate knowledge of gestational age. It should be based on first trimestral ultrasound or last menstrual period. And the most important and many times a missing link to define SGA is the accurate measurement at the time of birth of weight, length, and head circumference. So birth weight is taken very stringently. Every baby is born, but many times length and head circumference is missed. And I think we should improve our practice to include these two parameters also, so that we understand the further progression and understand the catch-up growth also in those babies who are born very small. So a cutoff against reference data from a relevant population, and this has been variably set at 10th percentile or 3rd percentile, or at least two standard deviation from mean. That is approximately 2nd percentile. Now, weight and length less than 2 standard deviation for that particular gestational age at birth, based on accurate anthropometry at birth and reference data from a relevant population. So we generally tend to use intergrowth charts to define the cutoff for gestational age and with respect to that, because we still don't have our Indian charts available for the same. And Fenton charts were also used previously, but I think the more appropriate would be, I think, intergrowth charts, which are more representative. Now we can subclassify them based on weight, length, which are that is SGA for weight, SGA for length, or both weight and length. Now, worldwide, the proportion of SGA babies is highest in South Asia and in European countries. The birth rate of babies of South Asian origin are lower than those of babies from other ethnic backgrounds. Now, IUGR is a different concept, which is
Hello.
Hello, Aniket, are you there?
Sir, Aniket, sir, voice is not coming. Sorry to interrupt you, sir.
Yeah.
Sir, I think he lost connection, I guess.
Okay.
Hello, Aniket, sir. He left the meeting, sir. I guess there's some network issues.
No problem. We can wait for some time. I think this is a technical glitch and
Okay,
his
sir.
call got disconnected.
Meanwhile, can we take a couple of questions till he joins in? There are a couple of questions in the chat box. Will it be okay so that we can save the time?
Yes, sir, we can do that. In the interest of time, we can.
Once Aniket joins, we can just continue with this session.
Sure, sir.
Dr. Sumit, is it okay?
Yes, sure.
Yeah. So one question was from the audience was, can growth hormone be given in familial short stature? And second was, when to stop growth hormone therapy after initiating the treatment?
Okay. So when we talk about familial short stature, we are in that again gray zone that we're talking about. So if we are growing below the 3rd percentile and we are looking into idiopathic short stature or some genetic cause, that first may need to be taken into consideration. And if the child is below the 3rd percentile, growth hormone could be given a consideration. Having said that, the response may be not as great, or it may vary depending on the type. And if this idiopathic short stature is fitting into skeletal dysplasia, we may not see a response at all. So it has to go through, the parents have to go through that counseling very clearly. And then when to stop growth hormone after starting it. So of course, once your bone age is showing epiphyseal fusion, then we don't want to continue it any further. But also if the growth velocity is less than 2 centimeters per year, there's no point in starting it, as long as we have adjusted the dose and increased the dose if needed, and still there is no response. Then if the growth velocity is staying below 2 centimeters, then we sure can discontinue it. Anything you would like to add?
No, I think yes, perfectly. And familiar short stature often.
Sir,
Grace
Sorry to,
for starting the growth hormone. Because as we know
sir,
that the
Prasant sir.
yeah.
Hello,
Finishing the
sir, good
answer.
evening. Sir, I think Aniket sir has
Yes,
joined.
I know. Yes. I'm just finishing the answer. That
Yeah.
familial short stature, as we know, the most important determinants is the early age as well as the mid-parental height. That means if you have a tall parent, the response with growth hormone is quite good. But here we are looking at a case scenario where the parents are also on the shorter side. So that is one thing that we have to tell them upfront, as you said clearly, that in familial short stature, they may not expect the exponential response, which we get it in the other US FDA approved indication. So that is one thing. Otherwise, I think everything is fine. I think Aniket has joined. Aniket, are you there?
Yes. Sorry for that.
No problem. I think
No.
Aniket, you need to put on your video, I guess.
Sorry, Prashant, my video will not be visible because my
Okay.
light is on in home. So
Okay. No problem.
just,
I think that should be.
but I think I have connected through mobile net, so I can
Sure.
continue with this.
Sure. Over to you. Yeah.
So is the slide visible now?
Yes, it's visible.
So we were just discussing about IUGR, and it is more of antenatal and a serial diagnosis rather than as a one point diagnosis like HCA. So basically, we require to at least 2 ultrasound measurements at least 2 weeks apart, and with fetal weight below the 10% for gestational age, and the important outcome is sometimes IUGR may born as HGA or it may not be. So all IUGRs are not HGAs basically. And HGA infants have not necessarily experienced IUGR. So basically the difference is HGA is like a photograph and IUGR is like a video. So these are the famous people all of you must be knowing who were born very low birth weight, but they have done a wonderful job in their own fields. So we'll just discuss about this physiological regulation of fetal growth. As we know, the most important driving factor for fetal growth is not growth hormone. It is insulin and IGF-1 axis. That's why we are worried about LGA babies in mothers who are having gestational diabetes because they have higher insulin circulating, which is transferred to the fetal side, and that leads to a higher weight of the babies. So just to throw upon a light on different genetic disorders which are associated with HGA. So since HGA is a blanket umbrella term, and under which we are now understanding various syndromes which fall, and few of them are delineated, and many of them we may understand in future. So Silver Russell syndrome is one of the classical syndrome, which can present as HGA. It is postnatal growth failure, relative macrocephaly, and protruding forehead, typical body asymmetry. They have feeding problems initially, and they have low body mass index. Many of these Silver Russell syndrome patients may also experience early puberty. That also causes their problem of final height being very short. So growth hormone therapy is effective in these babies if you correctly diagnose them in time and treat in time. Then Temple syndrome is one of the syndrome which is 14q32 abnormalities, and it is postnatal growth failure, hypotonia, delayed development, feeding problems, early puberty, broad forehead. So the classical dysmorphic features, and the diagnosis basically based on genetics. Then initially, Prader-Willi syndrome babies are actually failure to thrive, and they may also be born HGA. Till 1.5 or 2 years, they are very slow in growth, and then suddenly they start having excessive appetite and they develop obesity after that. Then pseudo hypoparathyroidism and is also can be a part of this genetic symptom. Now, growth in HGA, they are shorter during childhood and as adults. reaching adult height that on an average are approximately 1 SD lower than the mean. And most of them show catch-up growth actually during the first year, and is near complete catch-up happens by 2 to 3 years of age. GH, IGF-1 and IGF-BP3 or control index, these are not actually very useful to predict the subsequent growth as a predictive model. So it is a clinical and auxological follow-up that is the most important thing, which we have to continue in these babies who are born HGA. And one more important thing is that the feeding pattern sometimes these NICU graduates who are very, very low birth weight, neonatologists and other specialists try to do very aggressive dietary therapy, but that also is counterproductive because these HGA babies may have complications like type 2 diabetes, metabolic syndrome, PCOS in later years due to aggressive dietary intervention. So not much aggressive, not much slow, but adequate catch-up nutrition and catch-up growth is more important. So they should be measured every 3 months for first, every 6 months thereafter. The preterm HGA infant can take 4 years to achieve a height in the normal range. HGA have low lean mass and may have increased central adiposity. Calorie-dense feeding for HGA infant may not be appropriate as I already discussed. Now, mean IGF and IGBP3 are reduced in these babies approximately 1 SD. There is heterogeneity in mechanism of growth failure, right from insufficient IGF generation to IGF-1 insensitivity. Now, assessment of GH-IGF-1 axis may be required if growth velocity is persistently reduced and signs of GH deficiency or hypopituitarism are present. So, if actually specifically if we are getting these signs, then only there is a need to do GH-IGF-1 axis testing. And if there are no other red flag signs, we can start growth hormone without formal GH testing also if HGA is not showing catch-up growth by 3 to 4 years of age. Genetic abnormalities and polymorphism in GH-IGF-1 axis have been associated, and still they are not recommended to do. All HGA should not be subjected to genetic testing. So these are like IGF-1 and IGF-1 receptor gene deletion, point mutation, polymorphism, and additional research is needed to identify other candidate genes such as insulin and IGF-2. Now we'll just talk about the puberty aspect of these babies. It is the growth during puberty is also modestly decreased in these patients, whereas in girls, menses occur 5 to 10 months earlier than normal as a general observation. In those who do not, who do have early puberty, there is typically a rapid progression through puberty leading to loss of adulthood. HGA girls who display rapid weight gain during early childhood are more likely to have premature menses. And in boys born HGA, hypospadias and cryptorchidism are more common. They also have reduced ovulation rates, increased secretion of adrenal and ovarian androgens, and excess central obesity. So what is etiology of this earlier and quicker puberty? So maybe obesity, visceral adiposity, insulin resistance is one of the factors. So metformin was given in some of these studies pre-pubertally to delay, and it has been observed that it can delay puberty, menses, and increase the final height in some of these patients. It reduces fat mass and increase lean mass, and could high insulin levels alter pubertal timing and tempo? It is still a question to remains unanswered. So insulin and IGF-1 are critical in activation in kisspeptin neurons. So this is a study. You can see that the untreated and treated patients on metformin. So if you see the cumulative fraction of post menarche girls who are being treated, the menses were delayed, and almost I think 12 to 12.5 years was the 75% of them achieved menses, and those who were not treated, almost 100% of them, they developed menses before 12 or 12.2 years. Now, PCOS and SGA, insulin resistance from any cause can cause PCOS. SGA, preterm type 1 obesity, cortisol excess. So the combination of two causes, usually obesity plus other, increases the risk of PCOS and by increasing the insulin resistance. Premature puberty is also a common observation in them. In a similar mechanism is being proposed. Now, what are the neurological and intellectual consequences in these babies? It has been observed that they particularly have lower cognitive ability in maths and reading comprehension, and with more emotional conduct and attention deficit problems which they face. Long-term exclusive breastfeeding may prevent some of these impairments, and there is some evidence that growth hormone also improves IQ in short HA children, but additional data is required. Now, David Barker's keen observation have been popularized as Barker's hypothesis, or FOAD, that is fetal origin of adult disease. And it was his group that noted that low birth weight serves as the proxy not just for fetal but also adult health. And today LBW is associated with a host of chronic diseases, right from coronary artery type 2, many malignancies and osteoporosis to various psychiatric illnesses. So programming is a term which is used, which refers to the fact that that stimuli, when applied during a critical development, early development, generates a permanent changes in the genetic makeup, like methylation changes, and that is a area in which epigenetics is very keen to explore these things, and that persists throughout lifespan. So programming is not just limited to the in utero environment, but extends into childhood, whereas different organs and systems continue to adapt to various cues. So the transgenerational and socio-economic implications of FOAD have far-reaching repercussions that cannot be underestimated. Further research is still needed to understand these complexities. So infants who were subjected to mid or late gestational calorie restrictions were lighter, while those who endured the famine in early gestation had normal birth weights. So adults whose mothers were exposed to famine during mid or late gestation demonstrated reduced glucose tolerance, while those mothers who were exposed to this Dutch famine during early gestation revealed a more atherogenic lipid profile and higher body mass index. So although birth weight in some cases serves as a surrogate marker for development of adult disease, it is the in utero environment that sets trajectory for subsequent acquisition of childhood or adult diseases. I will just skip these slides because these are very not necessary for today's talk, and we'll go to directly summary. So LBW infants have decreased lean body mass and increased visceral adiposities. This sarcopenic obesity is considered one of the major culprits in the development of type 2 diabetes. And to promote survival during periods of starvation, food intake increases basal BMR, decreases energy, is preferentially stored as fat. So as we discussed, growth hormone is FDA approved at beyond 2 years who are not able to catch up. And European Union says that we should wait for at least 4 years to start the growth hormone therapy. The dosages are ranging from 40 to almost 70 microgram per kg per day. Now we'll just go to a couple of cases before we end this talk. So 2 months old baby born to parents who are cousins, multiple episodes of seizures, full-term delivery, and birth weight was 2.4. So this was HGA. NICU stay was there for hypoglycemia requiring GDR of 8 and prolonged jaundice. The discharge diagnosis was low birth weight, hypoglycemia, exaggerated jaundice. But this baby developed hypoglycemic seizure again after 4 days of discharge and started on anticonvulsants, but there was no response. He also had micropenis, and you can see the length and weight on growth chart. So at 2 months, growth hormone during hypoglycemia was low, prolactin was low, cortisol was also low. PT4.6, PSH was 0.005, and gonadotropins also were expected to be in mini puberty this time, but this was low. Ketotic hypoglycemia, ketones were positive. So in this baby, it was actually multiple pituitary hormone deficiency which led to this type of manifestation of recurrent hypoglycemic seizures. And this patient actually was started on growth hormone after 5 to 6 months of age and responded very well. Second case, it was persistent hypoglycemia. GDR was 12, BSL was 24, insulin was 1.2, cortisol 10, and GH was 20. Urine ketone was absent. So the pediatrician called and informed that this insulin was looking normal. And what should we do? So basically, whenever there is hypoglycemia, we should interpret the insulin with respect to hypoglycemia rather than the normal range, because this 1.2 insulin is actually abnormal for that degree of glucose. And this is basically hyperinsulinism, because ketones were also absent. That again supports us that hypoketotic hypoglycemia with this type of insulin level with higher requirement is hyperinsulinism. So these are the drugs which are given for this, and there are some newer medication which are being tried for hyperinsulinism, like avexitide and other. I think I'll skip this part and I will go to final slide. So when there is sepsis, although sepsis is the most common etiology for hypoglycemia, metabolic and endocrine causes should be considered if there is refractoriness and a persistently higher requirement. And we should start hydrocortisone before we collect critical sample in NICU as a blanket treatment, because once you start hydrocortisone, we are not able to assess the cortisol axis, and the diagnosis may be delayed because of that. And hyperinsulinism is the worst type of hypoglycemia because brain is also deprived of alternative fuel like ketones. So this is just a slide to show the critical sample evaluation based on ketotic or non-ketotic, and I think we can get it in any standard textbook. Thank you.
Thank you so much, Aniket, for giving the presentation. I'd like to thank both Dr. Sumit and Dr. Aniket for their lucid presentation. I think let's move on to question answer session. We have a couple of 3-4 questions in the chat box. We'll take it one by one. A couple of questions I think Dr. Sumit has already answered during the technical break. Yeah, so one was, what are the absolute contraindications to start growth hormone therapy in short stature?
Okay, so you
Yeah.
want me to answer that?
Yeah.
Okay, so we do not want to start growth hormone in any child who has been diagnosed with cancer, firstly. So if there's an active malignancy, you do not want to start growth hormone at all. If there is a syndrome where there is some sort of chromosome breakage kind of syndrome, where there is a genetic condition, for example, Bloom syndrome, again, that is a contraindication because of the risk of malignancy. If there is retinopathy, intracranial hypertension, then again, these are contraindications, but the absolute contraindication is again malignancy.
And even in Down syndrome, we generally do not use it for the same purpose, though they are very short. And often it has been asked by pediatrician or by the parents when they come to us for autoimmune hypothyroidism, that can we consider, just the way you're treating Turner syndrome with GH, can we give the growth hormone to Down syndrome? So Down is also in the same pre-malignant category. So the message to the audience that one should not consider a growth hormone to Down syndrome, though it's not an absolute contraindication. So perfect, very well.
And I think skeletal dysplasia, all we can, or
Yes. Achondroplasia, I think it's a clear cut. You won't say absolute.
These are not absolute contraindications.
It's like
but
use.
yes.
I mean, it will not be useful.
Yes, it's not an indication.
It's not an indication, you can say. Yeah. Second question from the audience to Aniket. I think this is related to SGA. Can we use a Fenton chart since we are using it for a longest period of time? And the next question is, I think, the same. Is it different from the chart which is shown in your presentation, Dr. Aniket?
Yeah, Fenton chart we can use. There is no problem. But I think it is Fenton charts are only derived, or the data baseline data is only for that geographical region. In contrast to that, intergrowth is at least representative of different regions as far as my knowledge. That's why it is all better to switch to intergrowth. But Fenton also will give you a fair idea about SGA.
Next question from the audience is, how do you follow up a children who are on growth hormone therapy, clinically and biochemically, I guess you want to ask?
For most part, I would go clinically, looking at their height and the growth velocity, and they're catching up their growth, especially in the first 6 months to a year. But if we do want to follow up and look at the IGF-1 level annually to see like if it is crossing the +2 standard deviation, we do want to look at if they are developing pre-diabetes also, which is one of the risk factors when starting growth hormone therapy. Also, we want to look at their spine to look at any scoliosis progression. Usually there is no new onset scoliosis that develops, but if there is already a pre-existing scoliosis, that can get worsened if growth hormone therapy is started.
Next question, I think for Aniket, can we give growth hormone in, I think they want to say precocious puberty in SGA?
Yeah, I think that is very zone again. So some of the studies I think have shown GH plus GnRH, right? Therapy. Yeah. In those who are having HGA with very early puberty, and those obviously were not treated in time before. So I think bone age assessment, prediction of final height, and that should be a deciding factor. And if bone age is very advanced, there is no point giving growth hormone or GnRH either. So if bone age is allowing us to have at least few centimeters to add up, then only I think based on case-to-case basis, we will decide to give that particular type of treatment. What is your take? You can just also add on this.
Sumit, you want to answer?
Yeah, usually when we're talking about starting growth hormone therapy in SGA babies, it is best done if it is started early because they are at risk of getting into precocious puberty and premature adrenarche, all that sort is there. But there are studies where they've used growth hormone and GnRH analogs in those that have started puberty, and there is some advantage that has been seen in these patients. So yes, that could be considered, but along with GnRH analog, to get some additional benefit. But again, if they have started puberty and their bone age is advanced, our predicted adult height will probably be compromised already.
Correct. I think what recent literature say that like if you have entered into your puberty and you have pubertal onset and your height is less than 140 centimeters, then in that scenario, if you are treating with GnRH analog, you can give them a GH, which will give you additional 2 to 3 inches. That is what it has been recommended. So you can remember that figure 140. The problem, I guess, with all of us is that either they are coming to us very late in puberty where their bone age is more than 12 years. So as such, their height is compromised. So to get that particular patient who is, will give the response, I think it's very minimal. I think what we see as an SGA, they already started with their menarche and their bone age is more than 12. I guess in such a scenario, GnRH analog is also not really, useful in increasing the height. I think the message here is GnRH analog would be a primary treatment for a height augmentation rather than a growth hormone, I guess.
Even in that scenario, even in precocious puberty,
Correct,
when we
correct.
are starting it, and if the bone age
Yes.
is above 12, we may not be able to get that advantage of height anyway, because like
Correct,
we
correct.
said, that estrogen is already causing that senescence of the
Yes.
growth plate, and the potential goes significantly low.
Absolutely. Then the $1 million question, what is the cost of a therapy? I guess he or she means to ask growth hormone. Correct.
Yes. So it depends on if we are using the branded versus the generic biosimilars. So if we're using biosimilars and if it's a younger child, the cost may be anywhere between 6,000 to maybe 7,000, 8,000. But if we're using the brands, it may come out to be 10 to 15,000 per month that I'm talking about.
So on an average, like 1 to 1.5 lakh per annum, you can say. Aniket, your take on cost of therapy?
Weight. So for 10 kg or 15 kg,
Correct.
you said is, I think, is. But Prashant, you can just elaborate on this also, that Mahatma Phule Yojana in.
Yes. In Maharashtra, do you have any particular scheme, Dr. Sumit? We have one scheme in government.
So we have that CGH central government that is
Correct.
covering, and
Okay.
then ESI is
ESI.
also covering.
Correct.
And I think state government Delhi is covering, but Haryana not yet.
Okay. In state of Maharashtra, we have Mahatma Jyotiba Phule Yojana, which covers almost, it gives you a 1 lakh, worth a cost of a premium for a growth hormone, which can be, reutilized every yearly. So if a child is 10 kg, he might get 1 lakh, which will be suffice for the first year. For the subsequent year, he has just to get enrolled, get admitted for 1 week or so, and he will get the growth hormone injection free of cost for that particular year. Only thing, he has to do it every annum. So that is very.
That admission also has to be shown.
Admission has to be there for at least 7 to 8 days as per that scheme. And you said the CGSH, ESIC, railway hospitals also, in fact,
Yes.
free of cost. The army, the Indian Army, Navy, to their kids, the growth hormone therapy is free of cost for certain indications like hypopituitarism and other things. I think the time has come that you have to decide about certain SGA with the advent, improved survival, and lots and lots of SGA have been getting cured easily and survived easily. I think government has to come up with some scheme for the SGA also. In fact, in Maharashtra, the Turner syndrome is also getting covered, but the problem is the cost cover is quite minimum. It is now reduced from 50,000 earlier, that is 50, to just 12,500, which is
hardly going to do anything.
Hardly a cost maybe for 10 to 15 days. So it's worthless exercise.
And actually they require higher dose, so there is no.
They require very high dose, 3 to 4 units. So it's not even worth to tell the parents about it. So we have stopped doing that sanction process for a Turner syndrome. It's only for hypopituitarism.
At least it's a start, and hopefully we're going to get.
Yeah. Yes, then the question is, at what age you start GH in SGA babies in your practice? Nikhil, you want to answer?
Yeah, it is again a variable. So how much below they are from the third percentile at particular, suppose at 2 years they come and already she is way below the third percentile. We are almost know that by 3 years or 3.5, she may not show a significant spurt. So those who are very low, then my take is 2.5 to 3 years we should start therapy rather than wasting the time, because as you know, the initial years the response is also good. As the age goes, then the first year response is also less. So practically all of you must be knowing that they don't get treated continuously for years together.
Yeah.
They just come in patches. So rather hit hard early and make them slightly okay. Even they lose to follow up again. If they come, then we can again take them up as and when it is possible. So 2.5 I think is okay, fine enough. But which are just on 3rd percentile and they are doing okay, I think we can wait for full.
Correct. I think Dr. You want to add in your clinic
Yeah.
is at what age? I guess you want to ask the practical question, like at
Yes.
what age that you see your patient to get treated with GH.
So it all depends on the parents actually. Like it's very hard to convince them at 2 years of age to start the
Correct.
injection. So I probably, I tell them that the US FDA has the recommendation starting at 2 years and the European agency has it at 4 years. So they choose to wait to 4 years. So for most part, it is for my patients, it's mostly 4 years only that I end up starting.
But
Because
my
then-
own question is, when do you see, like, then you both of you are very fortunate that you are treating at 2 years or 3 years, because I read that question in terms of like what is the maximum or average age. Generally, when we see that SGA, our age of referral is 6, 7, 8, 10 years. That is what.
I agree. So there is a
I agree.
very wide the reason I'm saying this is just recently I've had like a bombardment of SGA babies that are coming at 2 and 3 years probably
Very
these
good.
days because of these talks. And so so it's good. It's a good thing that I'm getting
Very good.
earlier referrals. So hopefully, I mean, the
Very
parents
good.
are also getting more aware and they're
Very
ready
good.
to take. But again, convincing them takes at least 6 months to a year. But they do understand that if we don't start, they're not going to achieve the predicted adult height. So they seem to be convinced too.
Very good. So I think the practical answer at the earliest 2 to 3 years, if they are deviating from the growth chart, and whenever you're seeing in your clinic at whatever age before the onset of puberty, I think we should just treat the SGA babies. Aniket, you want to add something?
No. I think if that aspect we have covered practically also.
Yeah, I think there are almost all questions been done. How long to give growth hormone in SGA children? For how long? Aniket, you want to answer in SGA?
Yeah, I ideally, the still they have final height, but I think
Correct.
at least 1 year, 6 months to 1 year, we should first give and see the response and then decide what to do further. The only biggest problem is again, now since many of the patients are affording, the finances are also not very big problem, but the daily injection, that is the main thing. After a few months, the kids are just reluctant to take the injections.
Hopefully Pfizer is listening and probably they will fasten their process of once a weekly injection.
Soon we are going to hear it next year
Yeah.
itself, right? Yeah.
Your take, Dr. Sumit, like how long do you give growth hormone?
As long as we can give it, actually, we
As
give
long
it
as
until they're
practically, I tell the parents that at least to see a significant result, you have to give for at least 3 to 4 years. Otherwise, you don't give. There is point in giving a short course. Often, as Aniket said, they generally fed up and either they do not come to your OPD or they just don't turn up. So this is what happens. So yes, I mean, there are practical implications of whatever we say in theory. We may not do that in clinical practice, but in ideal circumstances, yes, till their bones are fused, that is bone age of 14 or 15 years respectively, we can continue to give the growth hormone therapy in SGA as well as GHD or for that matter, all short children, I guess. So I think we are done with all the questions here. So thank you so much, Dr. Sumit and Dr. Aniket, for answering all the questions. Thank you so much.
Thank you, Prashant, for having us. And it was a wonderful discussion having it
Thank
together.
you. It's a wonderful discussion, really. And the audience is quite attentive. They've asked so many questions. So it's a very interactive session. So you have stayed with us for good 1.5 years. So thank you so much, everyone. So
Thank you.
I'd request Ankit to just conclude today's session. If there are any concluding remarks, over to you.
Thank you, sir.
Thank you.
So, on behalf of Pfizer, I take this opportunity to thank you, Dr. Patil, Dr. Arora, Dr. Kambojkar, and all the 71 attendees who are part of this meeting. And sir, we are really blessed to have all three of you today. And the value addition which you bring today to the life of patient with the help of disseminating this scientific knowledge is really appreciable. Because more and more awareness we have today in the field of pediatric endocrinology, more and more kids will be getting benefit out of the expertise which you people have today. So thank you so much for your time. Delegates, I really want to appreciate that on the Wednesday evening you invested your time. So I really appreciate that. And thanks to my Pfizer team and HiDoc team also for this seamless program. Because the way this program went, I didn't find any kind of glitch. So I really appreciate everyone for your time. And with your permission, now we can close this session.
Thank you. Thank you.
Thank
It
you
was a
so much. Thank you.
Thank you
pleasure to
very
be here.
much.
Thank you.
Thank you.
Bye-bye.
Thank you.
Good night.
Good
Thank
night,
you so
everyone.
much.
Good night, everyone. Thank you, IDOC. Thank you.
Thank you.
Thank you so
Bye,
much.
everyone.
Yeah.